Welcome to ClinMed Compass. Today, we are tackling a condition that kills more people than cancer or heart disease combined. I'm talking about sepsis. Today's lecture is focused on sepsis recognition and bundled care. This is a vital topic for both medical students and residents because early recognition and timely intervention saves lives. I am Dr. Emorican, and together we will break it down step by step. Grab your pen and paper and let's dive in. Sepsis is a major global health challenge. Each year, about 49 million cases occur, with 11 million deaths, accounting for roughly 20% of global mortality. It remains one of the leading causes of preventable deaths worldwide. Early recognition and treatment increase survival. And here is the shocking truth. Each hour of delay in antibiotics increases mortality by 7 to 8%. That is why we say time is tissue. Historically, we used the systemic inflammatory response syndrome criteria to detect sepsis. You needed 2 or more of the following: temperature above 38 degrees or below 36 degrees Celsius, heart rate above 90 beats per minute, respiratory rate above 20 cycles per minute, or partial pressure of carbon dioxide less than 32 millimeters of mercury, or white blood cells above 12,000 or less than 4,000 millimeter cube, or greater than 10% of the band form. Systemic inflammatory response syndrome is sensitive but not specific. So currently it is now replaced by SOFA and the qSOFA score in the 2016 Sepsis 3 definition, which we are going to see later. The definition of sepsis has evolved over time. In 1991, under the Sepsis 1 guideline, sepsis was defined as the systemic inflammatory response syndrome criteria plus evidence of infection. In 2001, Sepsis 2 expanded the systemic inflammatory response syndrome framework. In 2016, Sepsis 3 finally redefined sepsis as evidence of infection plus organ dysfunction indicated by a SOFA score of 2 or more. This shift emphasized organ dysfunction and not just inflammation, and this is the current context for the definition of sepsis. Currently, sepsis is defined as life-threatening organ dysfunction caused by a dysregulated post-response to infection. Organ dysfunction in this context means a SOFA score increase of 2 or more. SOFA means sequential organ failure assessment. It actually measures dysfunction across organ system. So what is septic shock? Septic shock is sepsis with persistent hypotension requiring vasopressors to maintain a mean arterial pressure of 65 millimeters of mercury and above, plus a lactate level greater than 2 millimeters per liter despite adequate fluid resuscitation. The mortality here exceeds 40 to 50%. Pathophysiology in brief. Sepsis begins with infection, but the body's immune response goes into overdrive. This activation of the immune system leads to cytokine release and inflammation, endothelial injury, and capillary leak. The resulting vasodilation and microthrombosis causes tissue hypoperfusion. If this cascade is left unchecked, all these processes will lead to multi-organ dysfunction and septic shock, and eventually death. Now we'll look at the SOFA score. SOFA means sequential organ failure assessment. It measures dysfunction across 6 organ systems, each scored from 0 to 4. and the total SOFA score expected is 0 to 24. It assesses respiration with the partial pressure of oxygen to the fractional inspired oxygen ratio. 2. Coagulation through platelets. 3. Liver through bilirubin. 4. Cardiovascular status through the mean arterial pressure and the use of vasopressor. 5. Neurological function with the Glasgow Coma scale. And finally, 6. The renal status via creatinine and urine output. A SOFA score of 2 or more defines significant organ dysfunction and high risk of sepsis. For bedside screening outside the intensive care unit, the qSOFA is used. It includes 3 criteria: a respiratory rate of 22 or more per minute, a systolic blood pressure of 100 millimeters of mercury or less, and altered mental status represented by a Glasgow Coma scale of less than 15. 2 or more points suggest a high risk of sepsis. So the qSOFA is fast and requires no laboratory tests, but is less sensitive than the full SOFA score. Let us look at the sepsis care bundles. Sepsis care bundles, they are a set of small evidence-based interventions that, when delivered together and on time, improve the outcomes. The aim is to standardize care, reduce delays, and improve survival through early recognition and urgent treatment of sepsis. The Surviving Sepsis campaign first introduced bundles in 2004. At that time, we had a 6-hour resuscitation bundle and a 24-hour management bundle. In 2008 and 2012, it shifted to a 3-hour bundle and a 6-hour bundle. And by 2018 to 2021, everything was merged into the 1-hour bundle. So currently, what we have is the 1-hour bundle. The lesson here is, the earlier the intervention, the better the outcome. We'll be looking at 2 bundles, Sepsis 6 bundle and 1-hour bundle. We'll start with the Sepsis 6 bundle. The Sepsis 6 was introduced by the UK Sepsis Trust. It is a practical bedside model delivered within 1 hour. It's expected that the components of the Sepsis 6 all will be delivered within the first 1 hour of development of sepsis or presentation. It includes 1. High flow oxygen to maintain saturations above 94%. 2. Blood cultures before antibiotic administration. 3. Giving broad spectrum intravenous antibiotics. 4. Administering intravenous fluid if there is hypotension or the serum lactate is high, above or equal to 4 millimoles per liter. Then 5. Checking the lactate levels. This assesses tissue perfusion. And 6. Measuring the urine output to evaluate the renal perfusion. To remember the sepsis bundle, the mnemonic buffalo summarizes it. B for blood culture, U urine output, F for fluids, A antibiotics, L for lactate, and O for oxygen. Always remember, sepsis 6 is buffalo. The Surviving Sepsis campaign 1-hour bundle is the current international guideline, unlike the Sepsis 6, which is used more in the United Kingdom. This 1-hour bundle mandates that all interventions begin within 1 hour of recognition of sepsis. Number 1, measure serum lactate. Repeat it if it's greater than 2 millimoles per liter. An elevated serum lactate will lead to an increase in mortality. Lactate is actually a marker of tissue hypoperfusion. 2. Obtain blood cultures before antibiotics. at least 2 sets of blood cultures from a peripheral and perhaps a central line, if present. This helps to identify the causative organisms and guide therapy. 3. Administer broad-spectrum intravenous antibiotics. The choice is guided by the local resistance, the source of infection, and patient's factor. Early administration of antibiotics reduces mortality. 4. Initiate rapid intravenous fluid resuscitation with 30 ml per kg crystalloid if the mean arterial pressure is below 65 millimeters of mercury or the serum lactate is 4 millimoles per liter or higher. 5. Apply vasopressor if hypotension persists. The target is to maintain a mean arterial pressure of 65 millimeters of mercury or higher. Non-epinephrine is the vasopressor of choice. However, vasopressin or epinephrine may be added if needed. In refractory shock, invasive monitoring is considered. This table compares the Sepsis and the 1-hour bundle. Both bundles actually aim for urgent treatment. Sepsis emphasizes simplicity for bedside care, especially in the UK. However, the surviving sepsis campaign bundle, which is the 1-hour bundle, is more comprehensive and globally standardized. Both bundles have overlap. Blood cultures, IV fluids, IV antibiotics, and lactate measurement is in both bundles. While the sepsis contains an additional 2 bundles, oxygen delivery and urine output, the 1-hour bundle contains an additional bundle to make it 5, which is the use of vasopressors. What is the rationale behind each step in these bundles? Each step has a purpose. Lactate tells us about tissue perfusion. Blood cultures identify pathogens and guide therapy. Antibiotic reduces mortality. Fluid resuscitation restores perfusion. Vasopressors maintain pressure and preserve organ function. From sepsis 6, we have adequate oxygen delivery and urine output, which reflects the renal perfusion adequacy. A brief on supportive care and monitoring. Supportive and adjunctive care are essential aside the bundles we've just discussed. For example, source control is critical. This may involve draining of abscesses, removing infected lines, or surgery if needed. Oxygenation, maintaining oxygen saturation above 94%. Mechanical ventilation, if there is refractory hypoxemia. Glucose control is also important. You maintain glucose below 180 milligrams per deciliter. Corticosteroid, important for refractory septic shock. Continuous monitoring should track the mean arterial pressure, urine output, mental status, lactate clearance, and dynamic hemodynamic parameters. In low resource settings, simplified bundles are necessary. Some laboratory tests and vasopressors may not be readily available in such settings. So the World Health Organization prioritizes 3 measures in low resource settings: the use of antibiotics, intravenous fluids, and oxygen. Clinical monitoring also relies on urine output, mental status, and capillary refill rather than advanced laboratory monitoring. So early recognition and basic care are the key in the management of sepsis in low resource setting. What are the challenges in implementation of some of these bundles? Despite guidelines, several challenges remain. 1. Delayed recognition of sepsis as a result of subtle signs. 2. Resource constraints in low-middle income countries. 3. Overcrowded emergency departments also create delays. 4. Clinicians must balance early antibiotic use with antimicrobial stewardship. And finally, training gaps among healthcare workers. All these factors actually affect implementation of sepsis care bundles. The future of sepsis care is promising. Biomarkers such as procalcitonin and presepsin are being studied. Artificial intelligence-based alerts within the electronic medical records may allow earlier recognition. Point-of-care ultrasound is increasingly used to guide fluid management or responsiveness. Precision medicine approaches may enable individualized therapy. Global initiatives are expanding awareness and improving access to sepsis care. To conclude, we look at some of the key messages in this session. Sepsis is a global emergency with high mortality. The SOFA and qSOFA remains essential tools for recognition of sepsis. Both the Sepsis 6 and the Surviving Sepsis Campaign 1-hour bundle emphasize urgent, time-sensitive treatment. In low-resource setting, these bundles must be adapted. Above all, the golden rule is think sepsis early, act fast, and follow the bundle. Thank you for watching this lecture on sepsis recognition and bundled care. If you found this helpful, don't forget to like, share, and subscribe for more medical lectures. This is ClinMed Compass with Dr. Morrican. Remember, early recognition and timely intervention save lives. See you in the next video.